Well, hello, everyone, and welcome to this edition of the Global PAD Association's Global PAD Impact Awards, where we are introducing you to the recipient of the PAD Rising Star Award for 2024. This prestigious accolade is designed to honor an early career physician who has had a profound and tangible impact already in the field of PAD through innovative research, advanced, cutting edge patient centered care, advocacy, and education. The recipient for this award exemplifies the qualities necessary to become a future leader in PAD. He demonstrates an unwavering commitment to improving patient outcomes, advancing the field through groundbreaking research, and serving the community with passion and dedication. I have watched this individual make significant strides in the realm of vascular surgery, particularly in the areas of diabetic limb salvage and critical limb-threatening ischemia. His work not only showcases technical expertise, but also a deep understanding of the importance of patient-centered care and achieving optimal outcomes. This rising star has quickly become a valued member of the vascular surgery community, contributing to multiple national and international clinical trials, and his research has been presented at numerous local, national, and international vascular surgical conferences, furthering our collective knowledge and inspiring fellow professionals in the field, having published multiple articles and book chapters that serve as valuable resources for both current and future generations of vascular surgeons. So it's really clear that this individual's dedication to improving the lives of PAD patients extends beyond the operating room. But you know what? You know what I think is the most remarkable thing about this individual is that he truly is just a wonderful human. His passion and compassion for patients is second to none. The stories that have rolled in from patients about this superhero, superhuman abound. Some would bring you to tears with joy, hearing the stories of restored hope and faith with limbs saved and lives changed. And I could go on and on and on about this doctor who just brings a smile to my face every time I hear his name or see him at a conference, because he is creating the change that we all want to see in PAD care. And I am so thankful that he has so many, 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 many more years ahead. And it gives us all in the PAD community a belief that there might be a light at the end of the tunnel. But it's about time I announce the recipient of the Global PAD Association's PAD Rising Star Award for 2024. It's Dr. Michael Sia, vascular surgeon at UT Southwest in Dallas, Texas. So please join me in congratulating Dr. Sia on this well-deserved recognition of his outstanding contributions to the field of PAD and, of course, his promising future as a leader in limb salvage. Hi, Dr. Sia. Congratulations.
Hi, Kim. Thank you so much. I've like kind of at a loss for words. It's super grateful. It means a lot to me to be recognized. Thank you for everything you do, and you know, got a lot of work cut out for us.
Yeah, and you're in the hospital. You just got off a tough case. You not only saved those piggies, but you're also saving a life today.
You just cut out. I didn't quite catch that.
Well, you're in the hospital today. Everyone can see you just got out of a case.
Yeah,
And you're
yeah.
not only saving those piggies, but you're also saving lives. And that's amazing.
Thank you. Try our best every day.
So I want to start from the very beginning. I want to start with your mindset, because as we dive deep into your skill set and your accomplishments and your promise as a future leader in advancing PAD care to a cure, putting the pressure on there, um, we will leave people wondering why there aren't more doctors like you. So I've got to ask, what childhood experiences shaped your this can-do attitude and belief that it's possible to make the impossible possible?
That's a great question. I think the easiest way for me to like wrap my head around it is, I think about my grandma. She was like a 60-pack year smoker, had emphysema, ultimately died of lung cancer, and she was the toughest lady I know. So tough that she routinely would be smoking cigarettes while on nasal cannulas at home. And I remember asking her as a little kid, like, Grandma, why can't you stop smoking? Or please stop smoking. she couldn't bring herself to do it. So I learned at a really young age that sometimes even the best, strongest, smartest people we love, can't make changes to their lives, even when we think we can help them. And rather than dishearten me, that just sort of motivated me to try harder and push her harder, and just try to be there for her more so. And it's sort of, I think about my grandma all the time when I take care of patients, and I think that's the light to which I look to. It motivates me and keeps me going.
Yeah, so that's basically we just I think got to the bottom of where your heart comes from, because I hear all the time from patients again that your compassion is just second to none. One patient even telling us that you reassured him that you both were married and that you would never leave his side in care. And I'm imagining that this compassionate spirit for patients really comes from that time with your grandma and really trying to be there for her and encourage her to do the things that she needs to do to live a better quality of life.
Yeah, absolutely. I've had some pretty phenomenal role models, people that they don't work in medicine, but they've devoted their lives to helping people and trying to make the world a better place. And they had tireless energy, so there's no reason why I shouldn't either.
So when did you first realize that medicine and specifically vascular surgery was your calling? And did you ever have any second thoughts?
I actually, my path to vascular surgery is pretty unique. I studied architecture as an undergrad, and realized around my sophomore year that while architecture is interesting and it's the art form we live in on a day-to-day basis, it wasn't something I really wanted to do. And one of my other mentors, who was a surgeon, basically identified that the things I loved about architecture, working with your hands, thinking about complex problems, um, being able to express your creative sides of your personality, are the things that you can do in surgery. Except at the end of the day, no one really cares what color the building is or what materials the building is made out of. In surgery, people care about outcomes and how people do. And for whatever reason, that just really, like, a light bulb went off in my head, and that motivated me to pursue a career in surgery. Not even just medicine. I knew I was going to be a surgeon. And then when it comes to vascular surgery, I was lucky enough to work with a pretty apex human being in Hawaii, Dr. Peter Schneider. And anyone spends any time with that guy, it's hard not to want to be like him. He's smart, he's thoughtful, he's a family man, and pretty much he pushed me towards vascular surgery. He sort of inspired me to pursue a career in vascular surgery. And then I got to work with vascular surgeons in California, all of whom pushed me even further. And then, before I knew it, I was at Georgetown in residency.
Wow. And vascular surgery is broad. So you have vascular surgeons who focus more on trauma, others on aortic aneurysms. Can you pinpoint that moment during your medical training when limb salvage became your passion? Was that Peter Schneider?
No, it was actually the vascular surgeons, or the diabetic limb salvage group at Georgetown, which really reinforced my early sort of interest in it. I got to work with vascular surgeon Cameron Akbari, who is like a second dad to me, who's dedicated his entire career to the diabetic foot and limb salvage. And in conjunction with him, Doctors Steinberg, Addinger, Karen Evans, Paul Kim, all of these people are either plastic surgeons, vascular surgeons, or foot and ankle surgeons. They made a team that was so fun to work with as a trainee that when it was time to graduate, I looked at Dr. Akbari and I was just like, I want your job. Like, I love your job. And fortunately enough for me, Dr. Kim, who's a foot and ankle surgeon, left Georgetown to go to UT Southwestern to start another diabetic limb salvage program, and he needed a vascular surgeon. So he reached out to me, and it was sort of like the stars aligned. It was perfect.
Wow. And I'm guessing that it all comes down to the fellowship that you're lucky enough to get or that you choose, because I had a vascular surgeon only months out of fellowship tell me just the other day that he has the skill set supposedly to treat complex CLI patients. And he added, though, that he would not use atherectomy devices as he's seen the damage that they cause. And he would also not treat the pedal loop in the foot, that amputation was the best option at that point. And it really shocked me. You're a CLI fighter, supposedly, as you're calling yourself, but you're not willing to use some of these advanced tools and techniques. And so I looked up his university and I talked to vascular surgeons familiar with that program and others. And I was surprised to actually hear that some of these universities are teaching future vascular surgeons to not use any of these advanced tools and techniques at all for any reason, and to not treat the pedal loop as it would, quote, just close. But you have embraced cutting edge methodologies in limb salvage and have exceptional rates in limb salvage comparatively. What really shaped your viewpoint and drives your willingness to adopt these advanced tools and techniques?
Well, thank you for saying that. I mean, I would say that anyone who takes care of patients with complex or even, run-of-the-mill peripheral arterial disease can be left wanting, irrespective of what modality of therapy is used, right? As a surgeon, I pride myself in my ability to do open surgical bypasses and endarterectomies and have the sort of wherewithal to determine sometimes, a patient's better suited with a minimally invasive endo option and other patients are better suited with an open surgical option. And even with the best endos, sometimes, we don't get the results we'd hope to, but the same can be said about bypass. So given that, it behooves you as an operator, it behooves you as a CLI fighter, it behooves you as a human being who's delivering care to try to find things that work better. And oftentimes that can either mean harkening back to older surgical practices, or more frequently, I'm embracing new technologies because in the hopes that they will work better than what we've previously had. And that's one of the reasons why I love participating in research and having access to investigational devices. It's because we're not just playing with widgets. We're scientifically analyzing how these technologies work and comparing them to historical precedences. And when we do that, we can determine whether or not something is going to work better. And if something works better, I think that that's what you should always be using to deliver the best, most modern care to your patients. So when I hear these things like people don't do pedal loop interventions, or people don't like to use atherectomy, or people don't want to try new things, I think that it breaks my heart a little bit, because sometimes these technologies are politicized. And when things get politicized, I think that it sort of prevents things. It prevents these technologies prevents these things from being used by operators and delivering this type of care to patients. So I would urge that young surgeon or young interventionalist, irrespective of specialty, to try to let go of the dogma that, you have drilled into your brain from training, because the goal over a long career is to be better after training than you were when you finished training, right? It's to get better every day, to get smarter every day, to be more insightful and thoughtful every day. And if you don't adopt new technologies, or you aren't open to changing the way you practice, you're going to stagnate and your patients will suffer.
So what do you think are the most significant barriers actually preventing this wider adoption from these advanced limb salvage techniques among vascular surgeons? Is it just that they're holding on to their textbook, or they're holding on to not want to betray whatever mentor they admire the most, that spent a lot of time with them? What do you think it is?
I think that in order to see widespread adoption of new technologies, I think most operators, irrespective of specialty, want to see level 1, grade A evidence in societal guidelines. They want to see high-powered, prospective randomized controlled trials. Hell, that's what I want too. But the fact of the matter is, these patients they show up in our office, right? You do one amputation, and at least when I have to do amputations, they break my heart. They represent a failure not only the care I deliver, but the healthcare system we all operate within, right? So if there's something I can do, if there's something I can try that can mitigate that risk, I'm going to do that. And I'm going to have a conversation using evidence and using my experience with every patient and their family member to give them the appropriate expectations, to give them an alternative to amputation. And granted, if someone doesn't want to do something advanced or something that not a lot of people in the country or the world are doing, I'm not going to force them to do it, but I'm going to give them an option and give them the best expectations I can possibly.
But this is one of my pet peeves. I really can't handle when a doctor says to me, show me the level one evidence and then I'll use it. Well, doctor, what broke your arm to help create that evidence either way? Just show that it works or show that it doesn't work. You're in the practice of medicine. Let's participate and let's work together to create that evidence either way so that we all know. But you got to get in there and practice.
There got to be people to do the cases to generate the evidence.
Exactly.
Right. Like, yeah, if I'm lucky enough to be one of those operators that is willing to take on the challenge to not only learn a new technology and deliver that technology to generate the evidence to change the way other people practice, like that's a very, very remarkable place in our community to be in. And I would be so proud to be somebody whose career is full of that.
Right. I mean, it's that can-do attitude that has really led you to paving new paths in the treatment of PAD. So I want you to talk about, building the limb salvage program at UT Southwest and the premise of the practice, which of course seems obvious, but it's one thing to call what you have a limb salvage program, but it's another thing to actually truly be it, and you are it.
I mean, people make a place, right? I'm very fortunate. Actually, this is a little bit of a grieving exercise. So the foot and ankle surgeon that recruited me, Dr. Paul Kim, in conjunction with my boss, Melissa Kirkwood, who's a vascular surgeon, gave me the opportunity to work side by side with someone who's dedicated their career, a foot and ankle surgeon named Larry Lavery at UT. And he and I, for the last 5 years, have shared a clinic on Tuesdays, much like, they did at Georgetown. So we'd be sitting next to each other, sharing patients, talking about patients. Our phones would never stop ringing from one another. Our text messages never stopped coming. But he and I really worked hard, not only at the county hospital for the first couple of years I was here, but moved it on over to the university. And, through our collaborations, our fellows got to work together. I got to work with all of his nurses. My nurse practitioners got to know their fellows, et cetera, et cetera. And we were able to make a very streamlined and efficient sort of pathway through the university, not only in the hospital, but for our outpatients. One of my favorite operations to do is any operation with Dr. Lavery, just because, he'd come, I'd do the arteriogram, the control rooms have this button where you can sort of voice of God into the OR, and he'd rib me a little bit. We'd talk about things. Oftentimes we'd leave with high fives around, and I could do the same when it was his turn to do his part of the procedure. But I think beyond that, we had the outpatient apparatus, the inpatient apparatus. We had a very effective means by which we could follow these patients, all of which are so important. It's been really wonderful. But Dr. Lavery left in September, and now he's at UT San Antonio. So it's a huge loss personally for me and for our program. But we do have a lot of really wonderful people that I continue working with.
It's good to hear because I've been waiting for a new contact over there in San Antonio. So now I think I have one. And I think I have some hope over there as well now, which I had lost hope over there for quite a while with so many of our patients getting amputated. But now I think I'm going to have hope restored again now hearing that Lavery's over there. So good news to hear. Bad news for you, but good news for folks in San Antonio.
Yeah.
So we all know there's no cure for PAD or any holy grail at this point. So you really, of course, got to be on the cutting edge. But I'm curious how you balance the risks and rewards when implementing new technologies or procedures into your practice.
That's a great question, and I think the eagerness with which I approach new peripheral technologies comes primarily from the fact that I am a surgeon. If I put something in that doesn't do what it's supposed to do, I have the ability to, rectify the situation by doing open surgery. I can remove something, I can readjust something, I can do a bypass. I can do all those things. So I have less fear, because I feel very confident in my ability to sort of handle it, whatever outcome may be. But I mean, at the end of the day, I'm a big believer in how our healthcare system works in making sure when devices come out or technologies come out or procedures come out, they've been vetted, they've been studied, they've been tested, and they are all safe. And, that's what I've seen. I haven't seen anything that's truly given me pause, that would change the way I approach using new technologies.
Nothing you regret trying?
I mean, I certainly think, when it comes to the arterialization of deep veins, because that is so novel, and I feel like the last 3 or 4 years, the key secret sauce amongst the people that were doing them wasn't widespread and widely disseminated. There were some things that we learned, things that I learned with Dr. Lavery, lessons that other people have learned, that if we could go back, maybe have done things differently. But I mean, ultimately, at the end of the day, we're all just trying to find the best answers for our patients. And
I think that would be a good question to ask then is, can you share a case in which there was a lesson that you learned or others could learn or did learn, can still learn? Describe the patient, describe the frustration that you had, and describe, the lesson that you learned in this particular case. And it could have been a success, it could have been a failure, either one. It could have included a little bit of ingenuity, which I know you have and you're filled with. But can you share a case?
Yeah, I mean, just going back to DVAs or the arterialization of deep veins, when we're dealing with these patients that are absolutely end stage, I think I needed to find partners that were willing, when it comes to the foot and ankle surgery, partners that were willing to give me grace, give these patients an opportunity to progress and not regress, as opposed to just saying, well, that looks really bad, it's probably not salvageable, you just chop the leg off. And finding those allies wasn't really as easy as I would have hoped it could have been, especially as a young surgeon who doesn't have the gravitas as some of the older, more established surgeons who have longer standing relationships with people. So that was a huge learning experience to me. Beyond that, just from a technical aspect, the postoperative management of those patients, almost antithetical to what we do conventionally when we revascularize patients with balloons or bypasses, where we try to remove the dead infected or necrotic tissue immediately and then close these patients. And closing a patient after doing a DVA within the first couple of days, led to a couple of failures that some were rectified and other people lost their legs. But I mean, it's a priceless learning point in trying to find solutions that can prevent amputation. It's when you think about these things, I was always taught, right? No surgeon won't have complications, right? If you don't have complications, that means you're not operating enough. But when you do have complications, you have to treasure them. You have to put them in a place that is sacred, because every complication is something you have to learn from. And that's the only way you can prevent yourself from making the same mistake twice. And I pride myself never making the same mistake twice, or trying never to.
So how do you approach that delicate balance between that aggressive limb salvage attempt and then knowing when amputation might be the best option? And how do you guide your team in that as well?
I mean, it's the patient. The patient and the family are the center of every decision. I'm aggressive. I love to operate. I will operate, but it's not about what I want to do. or how I want to do it, or wow, there's this new procedure I could do on this patient. It all centers around what the patient wants, what the patient can handle, what their expectations are, what their family network is like, what their life is going to look like over the course of the next 6 months to 1 to 2 years, right? Like all those things go into the calculus. And at the end of the day, if the patient is tired, if the patient wants to give up, give them the opportunity to be familiar with your perspective and why you think the way you do. But it's a conversation, and the patient's wants, wishes, and what the family wants is always what I do.
That's amazing. So can you share a particularly challenging case where your innovative approach led to a successful limb salvage outcome that still, just thinking about it right now, makes you smile?
Yeah, I mean, there are a lot, but there's one that is really meaningful to me. Um, you know, it's a lady, 65, call her Sally. And Sally was referred to me by herself. She sought me out independently after having been taken care of by a couple of other vascular surgeons in the community who recommended baloney amputation, BKA. And she sought me out, and she had truly no options. If I had seen her 5 or 6 years ago, I would have echoed the same sentiments as those other vascular surgeons. BKA, that's all you got. But we talked about it. So she's one of the first patients I did a deep vein arterialization on. And this is, I'm not as comfortable with that procedure as I am now when I was just starting out on them. And we ended up doing a deep vein arterialization on her. And, the first month she had a tremendous amount of pain. I may have picked the wrong blood vessel to use as a donor. Something I would have done technically a little different during the procedure now, if compared to then. I would have picked a different blood vessel, but she ultimately went on to heal, and she wrote me this beautiful letter about how she got to dance at her sister's 70th birthday party. And then she sent me a video of her dancing. And this was a lady that was told she needed a baloney amputation. This was a lady that was suffering. And, every time I see her, it's a big hug, and I mean, Sally means the world to me.
I love that. And we also have one of your other patients. We have Charles who's here, and Charles might want to say it just a couple of words in here because he's one of those that did help with the nominations. And he had such an incredible and continues to have an incredible experience with you. Charles?
Dr. Sia, good to see you. Not in office. When something that amazes me about you is even when you have to tell me something that's not so good, like you tell it to me, and then you give me that hope. Well, we're gonna fix it. A lot of doctors don't do that. They just tell you the bad part, and we're gonna try. But the way you encourage, and I'm sure it's just not me, but the way you encourage your patients that when they have to do an intervention, that they're going to come out on the other side and they're still going to have their limb. How do you go about doing that? Are you just that confident, or is it just part of your personality?
I love that question.
Mr. Winters, I don't know. I'm like an eternal optimist when it comes to human beings and my patients. Like I want your best outcome more than you do. I'm sure of it, or just as much as you do. And I don't think even in very challenging situations, like I don't think there's any need to be disheartened or nervous, right? Like I think you put your best foot forward and you're optimistic and you try your best and you have your plans and you communicate your expectations and you go and you try to do the best that you can do. And that's what I do every time I see you, Mr. Winters. That's what I do every time.
I thank you for it.
I'm trying my best, You get my best, 110% every time I see you in the office and every time I see you in the operating room. It's always my best.
Thank you. Thank you.
It's amazing. I mean, those conversations with patients are so powerful, and especially those ones when it comes to mitigating the risk factors. So, what role do patient education, lifestyle modifications play in successful limb salvage outcomes, and how do you incorporate these into your practice? What are the conversations that you have to inspire these patients to become better partners in their care? Because you're the plumber. You can only do so much. That's half of it. The other half is up to the patient.
Great question. I think one of the challenges in taking care of patients with wounds or pain at rest is, they have a bad problem that's associated with amputation, cardiovascular mortality and morbidity. And while we know that risk factor modification is so important, sometimes when they get to my office or get to the hospital, all I can do is meet them where they are. Yeah. Right. And I think that's what you have to do. You have to be willing to meet people where they are. You hear stories of people with, not intervening on patients because they smoke. And, that makes me think of my grandma. I was like, I get it. These people are dealing with, they have personal battles. They have challenging lives. They have challenging family situations. You meet them where they are and deliver the best care you can possibly deliver, while at the same time taking the time to communicate that if we don't change these things, even if we get a fantastic result, you're going to be back here. And the next time we might not be able to do anything, or the next time it's going to be harder than this time. So maybe that's a little doom and gloom, or maybe I try to frighten them a little bit sometimes, but I'm never going to turn anyone away because they don't take a statin. But it's also like a very important part of the preoperative and postoperative evaluation of these patients, making sure they're on best medical therapy, making sure if they smoke, they have access to smoking cessation programs, making sure they know that changing their lifestyle can lead them to leading a longer life with their limbs. And sometimes we're able to break through, and sometimes it's an ongoing battle. But I think all my patients, even the ones that keep smoking, when I ask them if they're still smoking, they will look at me and not be upset that I'm asking, but they'll smile and they say, "I'm sorry, doc, I'm trying." And I was like, well, that's all I can ask you to do. My doors are always open, though.
You're just incredible. I think anyone who's actually tuning in will understand why you have this award, and we've recognized you. But I'm so curious. I mean, you have this powerful technical skill set and just a huge heart. You have to struggle at times with balancing that technical aspect of your work with the emotional needs of yourself and your patients, especially when it comes to potential limb-threatening situations. Do you have a situation that you can share with us where you just were torn?
Yeah. I mean, anyone who takes care of these types of patients has had bad times. And, it's never, at least so far, it's never been like I did something and then something really bad happened to the patient. It's like, we were this like lovely lady, we'll call her Irma, right? And worked really hard to save her leg. We saved her leg. Mm-hmm. She gets admitted to the hospital. This happened relatively recently with a bowel obstruction. She languishes in the ICU. General surgery doesn't want to take her to the operating room. She's 90 years old, and they put an NG tube in her and put her on pressers. Her foot starts looking worse and worse. You have this great relationship with her daughters. I run into them not knowing that she was in the hospital in the cafeteria. And that's how I'm alerted to this. You go up there and you see her and she's not looking good. And, it's just it makes you want to cry. It really is tough because I think the hardest thing about this is you can try your best, but you're also taking care of patients that have so much other stuff going on. And, even your best sometimes doesn't save them, not necessarily from an amputation, but the worst outcome of all is passing away. But the way I navigate that, the way I deal with that is I've got incredible friends, I've got incredible mentors, I've got people that know how challenging the work we do is, and we rely on each other. Phone calls go multiple directions. Sometimes one of my former bosses or trainers will call me about a tough situation, and I get to be there for them, and that's incredibly rewarding. And knowing that it's a two-way street allows me to maintain my vigilance and my passion and my fire. And I'm blessed because of that, even though sometimes we see sad things like that.
Yeah, and I think it's important for the patients to actually hear a doctor saying exactly what you're saying, because even yesterday, and I sent you an email, not sure if you got it, that a patient that I was going to send to you, and you were graciously willing to accept and even transfer this patient because she had a wound on her foot that wouldn't heal. The hospital didn't have an advanced limb salvage specialist. Well, it turns out that she had other things. You mentioned the comorbidities, the other things going on. And I had just talked to this patient on Thursday, and I talked to her. She called me because she was most worried about this foot. She didn't want to lose her leg. Well, she ended up the next day thinking she was going in for a routine procedure, having a pacemaker placed, and somehow a bleed resulted in that. And they put her on palliative care overnight, and she was gone on Saturday. And I just talked to the patient's daughter yesterday, and it just brought me to tears hearing this. It was devastating to me. And this patient had such hope. She was worrying more about her leg than she was her heart, which goes to show how much the legs really do mean to each and every individual. And even at the expense of their heart. And this one, I'm trying not to go into tears with this one. She really meant a lot to me. So anyway, it's good to hear that I'm throwing myself off my own game with this one because this one is very fresh. But it's good to hear that you are also impacted by these types of situations. And I really appreciated you again being willing to step up and actually transfer this patient to help give her potentially the care that she had desired. So I know we have only a few more minutes left. I want to get to your goals because the Rising Star of the Year award is really about the tangible impact that you're having now, but the potential you have as a leader, within professional societies. So I'm curious what your goals might be in terms of leadership roles, and how do you plan to use these positions potentially to advance limb salvage?
I think identification of your goals is one of the most challenging things for any person to do. Something that you have to constantly revisit. But I think for now, I'm going to be honest. Like, I don't see myself being like a leader, have a major leadership position in the Society for Vascular Surgery. I don't know if I ever see myself becoming a chief or a chair of a department. But maybe that can change. I think like the biggest value that I can have is continuing to do the work I do locally here in Dallas, and also collaborating with other interventionalists around the country, irrespective of specialty, that are committed to advancing this subspecialty of cardiology, vascular surgery, and interventional radiology. And I think participating in a society or having a leadership position in a society that unifies the specialties towards a common goal of trying to, stem the tide of peripheral arterial disease, like that would be the most valuable thing that I could do. And I would love to work with others to develop a program like that or a society like that. Because I think the people that are dedicated to limb salvage, they get it, right? They get how hard this is. They have the patience and dedication to commit their careers to it. And vascular surgeons do so many things and are responsible for being experts in so many different things. I think that subspecialization is I think it's important at
Yeah.
least for me, and having an opportunity to work with like-minded people, that's what I want to do.
I think that's incredible. I mean, to be a leader is to lead by example. And if it's leading by example in what you do with tangible lives and limbs saved over the years, I mean, that's incredible. And I also love that you want to unify people. It's one of my biggest frustrations. The most advanced limb savers in the world are all unified. They all understand what it takes and the advanced skill set that it takes and the dedication it takes to save a limb. It doesn't matter what practice you are in. You are a limb saver. You're exhausting all methods to save a limb, and you're not giving up on the patient. You're giving up the patient even when necessary to get another opinion. And that's really incredible. And I'm with you 100% in trying to figure out some sort of additional ways in which we can unify not just this small handful of CLI fighters, but the entire gamut of vascular surgeons, interventional radiologists, and interventional cardiologists, because even collectively, we don't have enough doctors to go around, right, to meet the expected need as diabetes gets out of control, chronic kidney disease gets out of control, not just in the United States, but around the world.
Yeah, completely.
So what advice would you give to medical students or residents interested in pursuing a career right now in vascular surgery, and particularly getting them interested in limb salvage?
I would say that if you are lucky enough to want to be a vascular surgeon, I'd say approach vascular surgery hungry, devour it, learn everything you can possibly learn about limb salvage, about aortic surgery, carotid surgery, venous surgery, dialysis access, trauma. Know everything about managing critical patients. Try to make yourself the best version of a doctor and surgeon that you possibly can be. And keep your eyes open and your mind open, because you never know what you truly will develop a passion in. You know, I have partners that I work with that are fabulous surgeons, incredible surgeons, but they're like Swiss Army knives. They do everything, and they do everything pretty very well. And then I also have partners that are aortic specialists. They do aortic surgery. That's what they do. They're international and certainly national experts in that. And that's okay. There's whatever you want to do, what type of practice you want to have is the type of practice you should pursue. But should you be passionate about limb salvage, should you want to embark upon a career that's dedicated to saving limbs and lives, I'd say that, you know, we talked a lot about some of the challenges with it. These patients are sick. It's very hard. You have some really good days, and sometimes you have some bad ones. You have to have the emotional wherewithal to be able to take that on and take on the most challenging patients. Because I think, you know, most surgeons don't like clinic. I mean, that's the stereotype, but there are days where my clinic, there's nothing that makes me feel better. It's like better than operating, because the patients that you see, they're all embracing you. They're so happy. Their families are happy. It's so rewarding. And I'm very happy with the decisions that I've made thus far in my career. And I'm very excited. Just like what I tell some of my mentors, you ain't seen nothing yet.
I love it. I have two more questions for you, a little bit deep. And then if we have a couple questions from patients in our live studio audience, we'll get to those in the next few minutes. But I want you to share a case that had you scratching your head about how in the world this patient was not diagnosed sooner and what you wish would have happened differently with that patient. You could even share a story of a patient that might have come to you and they'd already had multiple other procedures that might have been okay, but they weren't the right procedures because they didn't relieve the textbook PAD symptoms. And if only they were diagnosed with PAD, things would have been different.
I mean, I'm very fortunate that in my area, there are interventionalists that, you know, tell patients they need amputations. You know, they have non-reconstructible vascular disease, they need amputations. And patients somehow wind up in my office. And the number of times that I've thought I was going to need to do a deep vein arterialization, a procedure for end-stage terminal PAD, only to find out they have like a short segment blockage in their thigh and 3-vessel runoff below. is pretty remarkable. So I've these DVA referrals that I've been getting, I've learned that they're not always DVAs. So I think that it's just a reminder that even here in a major metroplex, there are pockets of patients that, don't have access to not even reasonable care, but, the standard of care, sort of straightforward textbook operations that you could do, SFA stent, FemPop bypass, it's pretty remarkable. And I don't have one story like that. I've got, unfortunately, or fortunately for my practice, a lot of them.
We'll share 6 Minutes That Matter. This is our other series. It's called 6 Minutes That Matter, or Spur of the Moment. So 6 minutes that mattered in your career. It has to be a defining moment, a catalyst for change, a spark that led you in a specific direction. It could have been a conversation that you had with someone. It could have been a scene in a show or movie or documentary, but it even could have been a moment in which you witnessed something that was eye-opening. So tell me about those 6 minutes that truly mattered in your career.
I mean, that's such a hard question to answer. I would say that there was one doctor that I got to work with while I was in training named Steve Abramowitz, and he was a young doctor at the time. He's still a young doctor, but he's a big deal now. But Steve, when I was an intern, he was first year faculty, and Steve had a very unique way. Oh, you're fine. Steve had a very unique way of teaching. He was always so witty, so smart. But he always took the time to talk after cases about what you would do differently, what you could have done better, what you did really well. And those were always very, very meaningful, because when you're a junior resident, you're looking for all the feedback you can possibly get. Mm-hmm. Well, anyone with a busy vascular surgery practice, Steve, for example, has an incredibly busy vascular practice. Sometimes you get into things, you have problems with patients. And on one occasion, I had the opportunity to see this man that I admired, who's always so witty, funny, off the cuff. I had the opportunity to go with him and talk to a patient after, we had a bad outcome. And just seeing how someone so dynamic could be so serious, and then at the same time, despite the bad outcome, take the time to do the things that we always did, the rundown of the case afterwards. I remember being a junior resident and being like, wow, this guy's incredible. He makes the time for himself, his patients, and for his trainees. And, it truly is inspiring to me. And, he's somebody I count as a close friend and a close mentor. And even now, 5-6 years later, he still takes the time to do that for me. And, the best.
That was awesome. Well, we have 2 questions coming in from patients. Heinz, go ahead and unmute, and then we'll get to Douglas.
Hello, doctor. Congratulations on your award. I'm guessing that throughout your career, you've probably encountered people that have radiation-induced cardiovascular disease. And I'm curious, what have you found difference between them and the other cases you've seen with their arteries?
Yeah, that's a great question, and thank you so much. I would say in general, radiation makes my job harder. It's oftentimes very challenging to do open surgery on arteries that have been previously irradiated, just because not only does radiation affect the actual artery itself, but it affects the tissue surrounding the artery. It I would say obliterates the conventional anatomy that we rely on as surgeons. Now, one of the big differences when arteries get narrowed with radiation as opposed to conventional or, run-of-the-mill atherosclerosis is the nature of the narrowings are different. Usually with atherosclerosis, depending on where we are looking at it, the arteries have calcium in their arterial walls. And we don't see that as frequently in the narrowings associated with radiation. It's usually a thickening of the blood vessel in and of itself, but sometimes there can be calcium too. In those situations, depending on what the patient's symptoms are, like if her carotid artery is irradiated as opposed to, an artery in the pelvis, the manifestations that we're looking for can be very different, and that can affect how we decide to choose, or if we decide to choose to provide some type of therapy. But at the end of the day, everything goes back to the basic tenets of vascular surgery. It goes back to the patient. What are their symptoms? What options do we have depending on the anatomic location of their blockage? And what can the patient expect, not only in the early postoperative recovery period, but 6 months, 1 year down the line?
Okay, thanks.
My pleasure.
Fantastic. Thank you, Heinz, for jumping in. And how about Douglas? Douglas, go ahead and unmute and ask Dr. Michael Sia your question.
Yes, sir. Congratulations from fellow Texans. So congratulations. I'm curious, this is PAD month, and we've had a lot of great shows. And do you think doctors are having trouble today keeping up with the technology that is moving so fast with the advances and all of that, and in between the big cities and the little cities and all of that? And how hard is it to keep up with the technologies as they move?
That's a great question. I think one of the interesting things about people who are really passionate about treating patients with PAD is they aren't only in the big cities. In fact, some of the most advanced peripheral interventions in the country occur in rural Louisiana, with Dr. Walker and Dr. Nair and their massive group. So I don't think a location necessarily means that even if you're not in the city, you can't get state-of-the-art, cutting-edge interventional care. I don't think that. I don't think that's always true. But there are situations where, there is a lot of data. There are a lot of new technologies. There are a lot of new options for people to provide patients with. And it certainly does feel like sometimes it can be overwhelming. But at the end of the day, one of the things that drew me to the medicine, drew me to surgery, in particular vascular surgery, was that in and of itself. It was constantly changing and constantly evolving. And in order to do your job to the best of your ability, I think that every operator needs to dedicate time to continually educate themselves so that they can improve and provide patients with options that may be better than what we've had in the past.
Definitely. Thank you, Dr. Michael Sia. We appreciate you so much. The 2024 Rising Star of the Year Award through the Global PAD Impact Awards, brought to you by the Global PAD Association. Well-deserved honor. We appreciate all you do to save life and limb. Thank you from the bottom of my heart for everything. We really appreciate you.
Thank you, Kim. Thank you, everybody. This means the world to me, and I'm so grateful.